Greetings, everyone. Today is April 18th, 2023. We are excited to have you join us virtually and in person for the Behavioral Health Workforce Education and Training Interprofessional Integrated Health Education Series. Next slide. This program is supported by the Health Resources and Services Administration, HRSA, of the U.S. Department of Health and Human Services. Our grant numbers are listed for your review. We also have a way for you to sign in. Please scan the QR code at this time on your screen. You can also submit via text. That is 828-295-1124. To review tonight's agenda, I'm Dr. Katherine Y. Brown. I serve as moderator. I'm an assistant professor in the Department of Family and Community Medicine, Director of Communities of Practice and Dissemination at the National Center for Medical Education, Development and Research at Meharry Medical College. We will have a welcome by Mr. Ross Fleming III, Director of Behavioral Health Practice at Meharry Medical College. And our keynote speaker tonight is Dr. Regina Stokes of Offodile, Associate Dean of Student Affairs and Admissions, Charles R. Drew University School of Medicine and Science, Los Angeles, California. Following tonight's presentation, we will have a Q&A. At this time, we ask that you please keep your microphones on mute during the presentation. We do, however, encourage you to use the chat box for questions and comments. At this time, please give a virtual introduction by sharing your name, organization, city, and state. And remember, the Q&A will follow the presentation. Let's connect on social media. Please follow us on Twitter at PCTCOP and use our hashtag PCTCOP. We also invite you to share your Twitter handle in the chat box, and we will be sure to follow you. Save the date. Remember, tonight's presentation is part of the monthly Behavioral Health Workforce Education and Training Interprofessional Integrated Health Education Series. Our next lecture series will be held on May 20th, 2023, so save the date. For more information, we have listed our programs and our websites. Be sure to visit all of these amazing pages to hear about the work that we are doing. We also want to share a few members of our team. We work under the leadership of Dr. Patricia Matthews-Juarez. You've already met me, Director of Communities of Practice. Our psychiatry team. Our team, Family and Community Medicine. And our BHWET administration team. At this time, I'm excited to turn the presentation over to Mr. Ross Fleming III, who will introduce tonight's keynote speaker. Thank you again for joining.
Good evening, everyone, and welcome to the Behavioral Health Workforce Education Training Lecture Series. As Dr. Brown said, I just shared, I'm the Director of the Behavioral Health Practice. What I'd like for all everyone to do tonight is to make sure you turn on your cameras so we can see your beautiful faces this evening. It would be appreciated. Tonight's topic is telemedicine in graduate medical education and undergraduate medical education. Through an integrated health approach, the Departments of Psychiatry and Behavioral Science and Family and Community Medicine have collaborated with the Tennessee Area Education Centers to train residents, students, scholars, and other health professionals to work with persons in rural, vulnerable, and medically underserved communities. This approach will expand the number of behavioral health, family medicine, and other health professionals who will stay and work in primary care settings in Tennessee, as well as other rural areas, rural and medically underserved communities nationwide. Tonight, we have an opportunity to expand our residents, students, scholars, and as well as others training as they hear from a subject matter expert in telemedicine and telehealth. I hope you will listen and engage in this very important topic tonight. Our speaker for the evening is Dr. Regina Stokes of Offodile. She is the Associate Dean of Student Affairs and Admissions at Charles R. Drew University School of Medicine and Science, College of Medicine in Los Angeles, California. She is formerly the interim department chair of medical education, division chief of clinical skills and competencies, and director of the Pamela C. Williams Center for Clinical Skills and Simulation at Meharry Medical College. Dr. Offodile was actively involved in the MMC community, serving on the LCMCE committee, the admissions committee, and serving as the co-director of the Meharry Vanderbilt IPE Collaborative. She graduated from Charles R. Drew University of Medicine and Science, completed a surgical residency at King Drew Medical Center in Los Angeles, California, breast oncology fellowship at Stanford University, and a preventive medicine residency at Meharry Medical College. As a result of her interest and dedication to medical education, she has obtained a master's in health professions education and a master's in management of healthcare from Vanderbilt University. She has been certified as a health care simulation educator with the Society of Simulation in Healthcare. She is an advocate for unmatched medical students. She has continued to support the Med Fellows program for unmatched Meharry students. This program has a successful match rate of 90% after completing the program. And she is a proud mother of 3 sons, Cayenio, Chuma, and Hugo. I hope I pronounced those right, Dr. Offodile. I'd like to present to you Dr. Regina Stokes Offodile.
So good evening, everybody. Thank you for joining me, and thank you for allowing me to be able to speak. And so tonight we're going to have a conversation about telemedicine and graduate medical education and undergraduate medical education. And so I'm going to go ahead and start. So feel free to put questions or comments in the chat. And so with that, I'm going to begin. So kind of already went over that already. So he just left out one of the important things, and I was born and raised in Philly. So I'll add that. Okay. So we're just going to jump in. So what is telehealth versus telemedicine? So we always talk about telehealth and telemedicine. Well, we talk about telemedicine, but telemedicine is really, it falls under the umbrella of telehealth, which is yes.
Did you share your screen?
Oh, no, I didn't. Sorry. All right, I'm already flying through okay, so okie dokie. Let me see. So I can share on my part? Yeah.
Yes, and they will see it.
So where do I go? What do I do? I'm sorry. Where it says,
at the bottom where it says share screen.
Sorry, there it is. I think this is it. Let me see. Can you see now? Okay, great. Sorry. All right. Let me see. So, okay. All right. So, the objectives for this talk is really for, by the time you leave this talk, that you have a better understanding of the difference between telehealth and telemedicine. You understand the 5 major telehealth domains. That you understand the importance of the use of telemedicine in undergraduate and graduate medical education, particularly in light of the current COVID pandemic that we have, which really brought to light the need of it. I want you to all walk away with some understanding of how to perform a modified telemedicine history and physical exam. Also have an understanding of the importance of educating patients about telehealth, the benefits and the resources that are available to them. Also demonstrate how to supplement the traditional clinical teaching activities with virtual teachings. And also for the participants to understand barriers, whether they're individual, institutional, technological, to telehealth. And so with that, we're going to go ahead and jump right in. So I guess I need to put in, I'm sorry, you all, I'm just super challenged here. Okay, can everybody see? Yes? Okay, I'm just gonna thank you again.
Yes.
Okay, great. So telehealth versus telemedicine, they're sort of the same, but yet different. Telehealth is a subset of e-health. And so the use of telecommunication technology and the healthcare delivery, information education across the health resources and service administration. Telemedicine falls under the umbrella of telehealth. And this relates to specifically how telehealth is used in clinical services. So, but they both cover similar services, such as providing a avenue for providing medical education, and that is either for medical students, residents, as well as patients, to provide remote patient monitoring for patients who live in rural areas. You can use it to monitor their progress through their treatment plan. Also for a patient consultation, and that can be video conferencing, wireless health applications, and transmission of imaging and medical records. And that's whether the primary care doctor is consulting with a specialist. All right, so when was telemedicine first used? I know a lot of us think it was first used during, it all sort of sprung out of COVID-19, but it was first used for video communication for medical purposes, where clinicians at the University of Nebraska way back in 1959. And this was when they had a two-way television set up to transmit information to medical students across campus. But 5 years later, they were able to link it to the hospital and perform video consultations. So University of Nebraska, of all places, they were the sort of the cutting edge of using video consultations in telemedicine. So telemedicine in its sort of formal explanation is the provision of healthcare services over spatial distance through the use of telecommunication technology with the aim of benefiting a patient or population. And again, it's for people who don't have access to care or higher level care in the areas that they live, because they live in remote or very rural areas. And also it is evolved into being a means of care for people who are unhoused. All right, so telemedicine is also the delivery of health services remotely via telephone, via video, and secure messaging. It is also a subset of telehealth, and it refers to the use of communication networks to deliver healthcare services at a distance. So the World Health Organization clearly states that the delivery of healthcare services where distance is a critical factor by all healthcare professionals using information and communication technologies for the exchange of valid information for diagnosis, treatment, and prevention of disease and injuries, as well as research and evaluation for the continuing education of care providers, as well as all of those in the interest of advancing healthcare individuals and in their communities. So again, the World Health Organization is definitely an avenue for providing healthcare for people all over the world, rural, underserved areas, and definitely they use telemedicine, and this is their definition. So when we talk about telemedicine, there's 4 ways to use it, and the 4 major domains are whether it's a live video, whether it's synchronous, like what we're doing now, or we're talking, or whether it's a stored and forwarded, and it's asynchronous, where the video is sent from the patients in the video to the doctor evaluates it, and they can communicate back and forth, but it's not always in real time. It can also be remote patient monitoring. The patient can wear a cardiac monitor, and the doctor has access to the information that they need in order to help to fine tune or to create a treatment plan for patients with a given disease. Mobile health. When we go out into the community, that's another way of doing telemedicine or telehealth, and hooking individuals in areas where there are remote or where they just are unhoused and they don't have access or the means to get to healthcare providers. And again, it can also be used in the form of remote patient monitoring. So when we talk about live video is really a two-way interaction between the patient and the provider using audiovisual telecommunications or technology such as Zoom, which is what has primarily become the number one way of engaging in a telemedicine or telehealth interaction. It could be real time, and it may equate to or substitute in person, depending upon what the immediate need of the patient is. It's oftentimes used in the following situations. It can be used in an emergency room, in a rural emergency situation, like Savannah, Tennessee is a very rural area, and they have a small ER out there. So what you can do is you can communicate either with FaceTime, or you can use Zoom, or you can use the transmission of recorded documents or video to get assistance in the care of patients in the emergency room. And it can also be physician-to-physician consults, ICU monitoring, and consults. And that's typically between a primary care and a specialist. And the specialist may examine and evaluate the patient in remote locations. So a primary care located in a rural area can communicate with a specialist in an area that's very far from them, and they together can collaborate for the care of the patient in that area. So for the store and forward or asynchronous sort of way to do it, you'll have rural providers. Again, it's rural providers and patients who have access. They share secure health information with a specialist for a consultation and the care of their patients. And so that's very helpful when you think about access to care. Some patients, when people are in rural areas, they have limited resources. So for instance, Savannah, Tennessee, because I worked out there and it's really remote. And for a patient in Savannah, Tennessee to travel from 3 hours, 2 to 3 hours from there to Nashville, it can be a huge economic burden for them. And so using stored information and video from a physician in that particular area and having them share that information to a specialist in Nashville really, number one, benefits the patient, saves the patients the burden of finding the financial burden of travel as well as housing when they come, if they were to come to Nashville. So again, it could be for a distant or remote consultation using a review of x-rays for confirmation of a diagnosis, EKG for consultation and care of patients, and also for diagnostic studies that are not available for the patient in their particular area. They can travel to Nashville, have that study done, and then the physicians can communicate either through FaceTime or video call to really have a discussion about the diagnostic impressions from the studies and how that will work, how that will play out in the future care of the patient. So another one of the ways it can be used is the remote patient monitoring. So physicians are able to track and monitor patient progress and conditions remotely. So you can use it in electronic blood pressure monitoring that shares daily readings to a data bank that the physician has access to and can monitor patient blood pressure. It also can be used in a sense when patients use, oh my gosh, I'm blanking. The cardiac monitoring, a Holter monitor. It allows for something such as a Holter monitor. It allows for the physician who may be miles away from the patient to really monitor the patient's cardiac rhythm, looking for any abnormal events. And it allows, again, either can be recorded and sent later, or it can allow for real-time monitoring, prevention, treatments, and intervention with regard to wherever the patient's individual need may be. It also helps to reduce emergency room visits and admissions. So if a patient can have the opportunity to have a quick consultation with their specialist, particularly a cardiologist, if they're having some arrhythmia or unusual symptoms, they can have a telemedicine or remote encounter with the physician and save burden, the financial burden that the patient might have for the travel, for lodging, as well as for the higher cost of care. So, but it would, and in turn, will reduce the number of emergency room visits for the patient, which may or may not be covered by their insurance. So mobile health is another way, and you can use mobile devices to track and monitor patients' health and condition. Again, Holter monitors, blood pressure monitors that are, and even with the Apple, the Apple Watches, the amount of information that can be gathered from your Apple Watch and shared with your healthcare provider. So, and then again, also the use of mobile devices that provide health education. So it's not just in the care, but it can also be used, these mobile resources may be used to, and as a form of preventive care as well. So what are some of the benefits of telemedicine in post-COVID-19 era? So first we gotta, we really need to talk about like the impact of telemedicine during the COVID-19 pandemic. When the COVID-19 hit, it totally disrupted the foundation of medicine. All the ability for physicians to meet in person with patients, even just educating medical students, PAs, anyone that's a healthcare provider, the education of those individuals was totally disrupted, whether it's graduate or undergraduate medical education. So once we figured out the use of telemedicine, specifically the use of Zoom was a lifesaver. It enabled us to, number one, decrease the exposure risks during COVID-19. It also enabled us to care for those individuals who had chronic ongoing medical care issues, and to decrease the morbidity, the potentially increased morbidity and mortality associated with their diseases as a result of lack of access to care. And so some of the, the benefits that, in addition to what I just spoke about, using telemedicine in a post-COVID-19 or even during COVID-19, was that it was increased convenience. It helped patients to continue, who had chronic diseases, to continue the maintenance of their health care. It also decreased the transmission of COVID-19. It increased access to care, especially in rural areas and in lower income areas or lower income families. It improved patient outcomes. So when, if you weren't able to travel, travel was limited, access was limited. And if you had a chronic disease that required monitoring and very close care and adjustment of your medicines, the patient outcomes could have become worse, but it allowed for the patients to continue to have positive or improved outcomes. The increase in efficiency of the healthcare system. Again, it goes back to the emergency room. It decreased the burden that was placed on the emergency room at a particular time. And in doing that, it also decreased the transmission of disease. It reduces the cost of care. It's much cheaper to have a Zoom meeting as opposed to someone coming in, driving long distance, or going in and seeing a doctor. It reduced readmission rates, particularly for patients who had limited access to getting to their doctor because of the role of COVID. Cost savings for both the patients and the hospitals. It improved overall follow-up care. Patients were able to, in the comfort of their own home, be able to be on their computer, on their mobile device, and be able to have follow-up and feel secure and feel that their disease was being approached, their disease processes were being appropriately managed. And it also provided a higher patient satisfaction. And part of that is the patient had less stress and anxiety about traveling to the hospital. In the midst of the COVID-19 era, there's a lot of anxiety, a lot of stress associated with traveling to the hospital to get your patient care based on your chronic disease. And most people with chronic disease were at increased risk of getting COVID and having poor outcomes. And so having telemedicine during COVID and the post-COVID really allayed a lot of fear and anxiety for patients who needed continued care. All right. So some of the major telemedicine domains, number one, access to care, quicker care, convenient care, cost. Again, we talked about it briefly, that there's a lower overall cost just to have a telemedicine visit. The cost effectiveness, and with regard to, you can see more patients in a more timely and efficient manner, shorter visits, more efficient visits, shorter wait times. Also, clinician experience and the clinician has a wider scope of experiences, or more able to take care of a wider scope of patients. And it also includes actually improved patient follow-up. Patients are more likely to follow up if they can just go get on a quick Zoom call or a video call, as opposed to finding resources, finding time. If you're at work, you get on a Zoom call. It's much easier than leaving your job, going to a visit, and the whole process that takes. So now that we kind of talked about telemedicine, well, what really was the impact of COVID-19 on medical education? Well, we all know that it was very disruptive. It was disruptive, and it placed a heavy burden on medical education. Medical students and residents were, in a way, forced to step up and step out of the roles that they were traditionally in and become a major part of frontline care. So in 2020, abiding by the guidelines and social distancing recommendations, AAMC for many medical schools moved and transitioned their precursor curricular to online, which for many paused their clinical curriculum. So it was very disruptive. A lot, the skills, the exposure, the experiences that medical students and residents actually typically have, one-on-one patient care on the wards, in the OR, in the clinics, was disrupted, and it really impacted their ability to sort of hone and sharpen their skills. And some institutions, including Meharry, transitioned clinical skills curriculum to a virtual platform or format. So at Meharry, what we did during COVID-19 is we relied on Zoom, standardized patients, and mannequins. Like mannequins from the department stores. So what we did, and I'll just share what we did at Meharry. So what we did is we transitioned our first and second year curriculum with standardized patients in terms of teaching clinical skills, how to examine a patient. We transferred that onto to Zoom, and we use concepts like metacognition. So it's really thinking it's something called thinking about thinking. So what we did is we taught the students and discussed with them like how you would walk through a history and a physical exam. How would you ask the questions? What was the manner in which you would perform a history and physical exam? And so as they begin to think about those processes and very sort of articulate how to walk through a physical exam. During the physical exam, in this particular, like if you would say, well, how would you perform a cardiac exam? We would talk to them about, and then they would say, if I were, right now I'm going to do a cardiac exam, I'm going to listen in the second intercostal space, midclavicular line on the right. I'm going to go to the other side of your sternum, and I'm going to listen on the left. And they would actually they would actually describe what anatomic landmarks they would be placing the stethoscope in order to articulate their understanding and knowledge of how to perform a cardiac exam. And so also when we were doing clinical skills, when we were running our OSCEs and our assessment of students and their clinical skills in the third and fourth years, we use mannequins. We would have the students came in one at a time, they picked up a mannequin, and they would go through the exam on camera and demonstrate how they would do the exam on the mannequin. And so that's how that's how Meharry in clinical skills for our clinical skills and medical education curriculum, that's how we utilize Zoom during COVID. So other institutions transition their clinical skills curriculum to a virtual platform and format, and that's exactly what we did. We were very creative in the way of how we were able to sort of still teach remotely how to do an exam that is typically face-to-face and hands-on. So some of the benefits of telemedicine, it's been found that there's increased trust between the physician and the healthcare provider, where there's a physician, nurse, standardized patient, physician, nurse, physician assistant. And so they noticed that there was an increase in trust because it was a more sort of focused, intimate sort of interaction. There's decreased patient anxiety. The patient is in the safety of their own home. Also increased compliance because there was no need to travel. There was no excess financial cost to seeing the doctor, because, most people would have the app, and if you just need the app, and the provider will provide you with the link, and they were the ones who actually covered the cost of using Zoom. Increased participation of the patient in their healthcare. It also increased the participation of family members in the care of some patients that needed additional individuals to be present and to help them to process their treatments and their assessment of what was going on. It was much easier for family members and other healthcare care providers to be involved directly in the care. So it was also a big thing was convenience. 79% of the patients said that scheduling a telemedicine follow-up visit was more convenient than arranging an in-person follow-up. Again, you didn't have to leave the comfort of your home. It's easier to say, oh, let me stop doing whatever I'm doing. I have a quick 10, 15, 20-minute follow-up visit, get on my Zoom, have my interaction with my doctor, very personal and thorough and intimate, and boom, I'm done. I don't have to worry about parking. I don't have to worry about how much gas costs. So it really increased the amount of follow-up. Telehealth visits are very thorough and very personal. You one-on-one with you and your doctor in the comfort of your own home. And again, it allows patients to be more accessible to sharing, amenable to sharing what's going on with them, sharing any personal or really intimate information in the comfort of their own home. They're more likely to be free and open. And again, it allows for open and effective communication between the patient and the clinician, because again, I'm in my safe environment. I feel safe and comfortable, and I feel free to share whatever's really going on. So telemedicine and undergraduate medical education. So, during COVID, post-COVID, for me, telemedicine really kind of is sort of anchored in COVID, but post-COVID, we're still using it and making it grow for us. But its use in telemedicine undergraduate medical education allows for the use of asynchronous lectures on how to take a telehealth history. So again, you more than like we had increased attendance when we were giving our lectures over Zoom. Students were more likely to show up and to be active and involved in the lecture. And in particularly when we were sharing on how do you take a telehealth history, but a telehealth history is very similar to the history that you take in person. And so delivering lectures on applications, ethics, safety, etiquette, and patient considerations in the use of telemedicine. Those things are very key because you have to be very mindful of your physical presence and your ability to maintain eye contact, their ability to present your body language in a way that is open and caring and allows the patient to understand that even though you're remote, you're still very in tune to what they're talking about and their concerns. Is the use of faculty supervised standardized patient telehealth encounters. So again, whether it's an undergraduate or graduate. So an undergraduate is using standardized patients, but however, in graduate medical education, it's the residents. The residents are conducting telehealth visits on their own or with the supervision of their primary care proctor or mentor or attending. But for the most part, once they do one or two, they're going to be doing a lot of telehealth visits on their own. And so really having the initial first sort of supervised experience and then moving into going telemedicine on our own. So it's very helpful in training our future healthcare providers, medical students, residents, nurses, PAs, nurse practitioners, anybody who is a healthcare provider at all, is very applicable to go ahead and train, and beneficial to train them in the use of telemedicine. So also hands-on diagnostic and therapeutic procedures using telemedicine equipment. So, being able to talk a patient through doing an exam, or having another provider be able to be there and to facilitate procedures as well. Also, the increased use of telemedicine during COVID and post-COVID era, medical students have increased exposure to its use, as we said before. And that's whether they're doing a one-on-one or in a group setting, whether it's a simulated setting or a real patient encounter. But I don't want to say real patient encounter, but even when you're doing simulated encounters with standardized patients, this is still a real patient encounter. Also, it allows for increased telemedicine and it's increased training in telemedicine and undergraduate medical education. When before, like when I went through, if someone told me we were going to telemedicine, I wouldn't know what they were talking about. But for the current generation and future generation, it's a key part of their training. So also you can use it as an assessment tool. So there has been there's been a lack of assessment in telemedicine, undergraduate and graduate medical education. There's a lack of assessment of it on licensing exams. But in the context of what COVID-19 did, it helped us to be creative in the way that we use telemedicine or teleassessment, actually is what we probably should call it, when we're using having students in a virtual setting, virtually interviewing a standardized patient, and a supervising physician or instructor is also on that visit as well. And while the student or the resident is interacting with the patient, they're also being assessed by their instructor or another healthcare provider. And then it would be given feedback as to how they would be able to improve the communication between the patient, how they would be able to improve their ability to deliver a virtual or telemedicine physical exam in a way that they would be able to get the core and critical information that they needed to create their differential diagnosis and treatment plan. So again, telemedicine and GME, so teleprecepting, that's having a primary care physician be on a video call with a resident while they're actually interviewing or doing a procedure. So they can in real time still be able to provide feedback to students or feedback to residents as well. While they're doing that. In rural medicine, and a study by Harvard University was found that the use of telemedicine has increased by 28% on the level of GME. The RUPRI Center for Rural Health Policy and Analysis policy brief reports that 1/3 of urban and rural hospitals use telehealth to increase access to specialty care for their rural patients. So again, as I mentioned before, it can be a financial burden for patients to come from rural areas into Nashville per se to the larger primary care or healthcare delivery systems. It's just to travel alone, then the need for housing, and on top of the need for the cost of care. So by eliminating the travel and the housing, it makes accessing healthcare a more reasonable thing for people who are in the rural areas, and even people who are in the more city areas, and you can still have access to care issues. People might not be able to they don't have a car or they don't have a mode of transportation, but everybody has a cell phone. And a cell phone is really all the patient really needs. But almost everybody has a cell phone in this day and age. So even if they're within within the area or range of, but some people still don't have access. They don't have a car, they can't afford a bus, or, they can't afford a Uber, they can't afford transport. So, but having a cell phone, whether you're homeless, whether you're unhoused, or whether you just don't have the resources, you can use your telephone as a way to get healthcare, even if you're not in a rural area. So rural healthcare providers were found to use telehealth for emergency medicine and radiology. So again, they're in a rural area, they send their x-rays out to a distribution center, a radiologist reads it, the radiologist sends the information back. That's telemedicine. They send the reading of the x-ray, or if it's a critical finding, they'll call the physician in their rural ER, share with them the information so they can expedite the patient's care or transport to a higher level of care. So an assessment, the lack of assessment, some of the concerns about telemedicine has been, number one, a lack of assessment in telemedicine in undergraduate and graduate medical education. Probably not just a lack of assessment, but maybe a lack of a sort of standardized way to assess it. There's no way for medical licensing exams currently to assess someone's skill set in telemedicine. It's not actually really currently being assessed, but I'm sure that's going to be coming. So there was a survey by the American College of Emergency Medicine of medical students in the United States and Canada revealed that less than 5% of them were satisfied with the telemedicine training. So prior to COVID, many of them probably never had telemedicine training. And then with the sort of just then with the explosion of COVID-19, the telemedicine training was probably poor because a lot of the attendings probably themselves did not have a lot of training in telemedicine. And so 7% of them felt that they were not as prepared to practice telemedicine. But then again, you have to remember, it was not a huge thing for the medical providers that were teaching them. So it was definitely a learning curve for everyone. So telemedicine and simulation, telehealth specific knowledge and skills to incorporate into clinical case design. So when you think about telemedicine and simulation, the first domain is compliance. Are there a set of rules of what needs to be done in the patient? Privacy and confidentiality, patient safety, technological skills, telehealth delivery, assessment and diagnosis, and care planning and management. So when you think about using simulation in telehealth, telehealth simulations are designed for learners to practice skills and to adapt these skills to a clinical context, such as Zoom, because that's what we use. So pretty much when we're teaching and using simulation to teach telemedicine, we usually have a pre-brief room. That's the main room where everybody's in a room. And you kind of give the rules of engagement. You tell the students, okay, you're going to have a clinical encounter with a patient. These are some of the things that you need to think about. Please be mindful of, you want them to be mindful of their physical, their sort of telehealth presence. Are they engaged? Are they looking at the camera? Are they talking to the patient? Are they their body language? And then so once they get their pre-brief, they go out to their breakout rooms and they each have a telemedicine interaction. And that's basically, they're going to do a history and a modified physical exam for the patient that's participating, or the standardized patient that's participating in the telehealth simulation. And so then what's going to happen next is they're going to come back to the main room, and then we're going to do a debrief. And then actually they'll debrief initially with the standardized patient. The standardized patient will give them feedback on an individual level, and then we will go and debrief. And you can debrief in a larger room, asking overall, how was the experience? Did you feel that there was an adequate connection? Were you able to perform or obtain the information that you needed? You would also allow the standardized patient or simulated patient or actor to provide feedback to the student, and not just feedback on the student's performance, but feedback on the actual experience. How did they feel in this simulated exam? What ways did they feel it could be improved? And whether that has to do with the student's performance, or just in the context or the experience or the circumstances of the virtual experience. Also, what you also want to think about is fidelity. How accurate, how close to real, to it being or feeling real was it? So when you think about experiential learning, you have to, you're seeing the patient's perspective. You have to see how, I'm sorry, my I don't know what, okay. Anyway, how the patient's perspective, how did they feel in this sort of virtual setting? Did they feel that they had the same or almost the same experience as they did as if it were a in-person experience? You want to think about, you want to have a reflection on the patient's experience. You want to understand a client's point of view. Someone is at the front door. I'm sorry, someone's ringing my doorbell. I'm sorry. So understanding the patient's point of view, number one, did the patient feel that the doctor was fully engaged? Did the patient feel that the doctor really addressed the physical exam, complaint that they had? And also, you have the opportunity to improve a learner's self-efficiency and communication skills. So, and that comes mostly when the standardized patient gives the student or the learner, it could be a resident, feedback, not constructive criticism, but feedback on what could have been better in the encounter. And so I don't like to use constructive criticism, because criticism is not really, it's never positive. So you want to allow the mentor, you want to allow the faculty, and especially you want to allow the standardized patient to give the student, the resident, or even the physician learning about telemedicine. You want to allow them to give feedback to the provider, to allow them to have insight into how they can actually improve the delivery of care via telemedicine. So when you think about implementing a telehealth sim, so number one, you got to figure out what's the location. Well, you can do it on, it could be the learner could be in the clinic, the learner can be in their office, it could be in a hospital, or it could be remote. The physician and or the learner can be at home. So, but you got to identify the location. You want to do a pre-brief. You want to let everyone know what are the terms of engagement. You want to make sure that the student and or the resident understand what it means to engage in a telehealth experience. You also want to, when you're doing simulation, it's very key in simulation that you want the individual who is going to participate in a simulated event, that you ensure that their physical safety and their psychological safety. Sometimes you can be involved in a simulation. It can be and you not always going into it, not always understanding people's or a participant's prior experience. And sometimes it can be so real, it can mimic a very emotional or terrifying experience that they had, and it can cause some kind of psychological upset. So you always have to pre-brief and debrief. So then after the pre-brief, you tell everyone what's the terms of engagement, what's going to happen. And then the case in the telehealth sim, it begins. And typically when you're doing a telehealth encounter with a standardized patient, it usually begins with a virtual history. The medical student, the resident, the provider engages the patient in obtaining a virtual history. But then it also progresses to a virtual physical exam. And a physical exam in a virtual setting is a partnership, because number one, the physician is instructing on some level of and telling the patient what they need to do in the physical exam in order for the physician to elicit clinical findings that they may find are important to confirming or coming to a differential diagnosis. And so once that's done, then you're going to debrief. You want to know, how did the patient feel in this virtual telehealth simulation? What emotions were brought up for them, good, bad, and different? Also, you want to check the emotional safety of the student, the resident, or the physician that's involved in the simulation. Where are you? How are you emotionally? How did this encounter impact you? And then you want to give feedback. The observer will give feedback, the standardized patient will give feedback, and the learner will also give feedback. A teleoscopy is a simulated telemedicine training for medical students. And so an OSCE, in case you don't know what an OSCE is, an objective skill clinical exam. And at Meharry, we use them for formative and summative assessment. So a formative assessment is really like a quiz. A formative assessment is like an exam, or like your final exam. No, I'm sorry, a formative is a quiz and a summative is like your final exam. And so we'll usually include a teleoscopy in a quiz or a formative, or we'll use it as their final exam, particularly a formative exam to assess telemedicine skills of third-year students. You're going to have a standardized patient, a student, and a faculty observer. And it's conducted with all three participants. It can be remotely, or the patient can be remotely only. So you can kind of modify how it can be done. Usually we're going to be connecting with Zoom. Zoom is typically the platform of choice, unless there's a video conferencing platform that is available through the hospital, Skype, but not everybody, I don't think anybody uses Skype anymore. I don't know. And then also virtual meeting rooms. And so there's three competency areas that can be assessed using a teleoscopy for medical students. You want to evaluate their communication skills. How did the student communicate with the patient? Were they able to elicit an adequate history? Were they able to understand show an understanding of the pathophysiology of the disease process that is involved in a chief complaint? The patient comes in with abdominal pain. Were they able to perform a history and communicate to the patient that they had some idea of how to do a history of present illness surrounding that chief complaint? Their clinical knowledge, based on the history gathered during this session, the student should be able to perform an appropriate physical exam. So if the student was able to communicate with the patient effectively and obtain the key historical findings, then they will be able to progress to the appropriate physical exam. So there's certain kind of anchoring physical exams that you want to have in anchoring procedures you do in a physical exam. And we kind of teach that you're always going to do a heart and lung. And then from the heart and lung, you want to move out to where the chief complaint sort of centers for the patient's complaint, and focus your physical exam in that particular disease system. So based on clinical knowledge, they had a history that they gathered during the session, and they were able to perform the appropriate physical exam. The patient-centered use of technology, being able to really continue to have the patient engage using Zoom, Skype, or whatever it may have been, and that they were able to do the physical exam and have an understanding of the geographic and economic realities of patients. Being able to assess that, okay, I understand you can't come in. I understand, again, financially, travel-wise, or just your illness in general does not afford you the opportunity to come in, but that you are still able to meet the patient where they are and provide the appropriate personal empathetic care that the patient is desiring. And so this is a slide about metacognition, and it's really the intentional thinking about how you think or learn. Once you think about your learning process, how does that play a role in your ability to interact with a patient when they're not in front of you? All right. And so, cognition is thinking about activity and processes. Metacognition is intentional thinking about how you think and learn. What are the steps that I need to follow here? I'm wondering if I need to do the physical exam in this particular way. Can I translate or describe to the patient what to do so that I can get the information I need? What do I really know about this topic? What did I get stuck when I was trying to solve the problem? So how did I get stuck between understanding the chief complaint, getting the history, and then performing the appropriate clinical exam? Maybe I missed something in the history and it made me leave out a part of the physical exam that was really impactful in determining what's going on with the patient and how I could deliver the appropriate care. And then, reflection. This reminded me of when we were in the pre-COVID phase when I was speaking to a patient who had a gallbladder problem. So I understand based upon that encounter, how can I abridge or amend that interaction and have it be effective in a remote setting? And what is the assignment? What is the assignment asking me to do? Like, really, what am I supposed to do? Like, how do I do a history? Do I do a history only? Do I need to do a physical exam? What a physical exam do I need to do? And, am I figuring it out? Am I going down the right path? Sometimes it just takes one question or one thing and you're off on the wrong path. So am I evaluating and doing self-checks as I move through this sort of virtual remote sort of engagement? So again, it's the intentional thinking about how you think and learn. And then cognition, again, your thinking activities and process. Am I reassessing and processing as I go? So again, it involves knowing yourself as a learner, knowing your strengths and your weaknesses. If you can explain what your strengths are in academic writing or an exam taking or other types of academic tasks, you are metacognitively aware. This process can be applied in learning and thinking in all discipline and contexts, and is an essential skill and for lifelong learning. And it's also an essential skill for assessing, am I really capable of doing this particular exam or doing this particular study? Am I capable of relaying this very complicated procedure to the patient in a way that they can actually understand? And so it is also really about being a self-aware learner. Am I checking in on myself on what I really know about a given topic before I go and talk to a patient? Do I need to stop outside the room for a second and say, let me take a look at this and see what this chief complaint really means, or what do I really know about this topic? Okay, so what are some barriers to use? Limitations in performing comprehensive exam, possibilities of technical difficulties. Zoom can go out, it could be the internet can go out. So there's a lot of things. Breaches is security breaches. There's PMI, the medical information, that is private that you shouldn't be sharing. Sometimes during, it was noted that during COVID-19, there were people who would get into meetings and encounters with patient and clinical encounters that really had no business being there, but they learned how to, I don't know what you call it. They learned how to break into those encounters. And so again, security breaches, regulatory barriers, telehealth rules and regulations are based on location and are constantly evolving. And the fact that for a while there was unclear standards and regulations, like nobody really knew like what we could do, what we couldn't do, but we were just trying to get it done. We were trying to make it work until, basically fake it until we make it, until we were able to develop some core competencies surrounding using telemedicine, Zoom, in COVID-19 and post-COVID-19 era. So again, physical exam during telemedicine. There's some exams that, number one, you just cannot do, but there's some that are amenable to telemedicine. So the musculoskeletal exam, neck and shoulder, elbow, wrist, hand, any joint. How can you assess it? You can ask the patient, can you show me your elbow that you're having pain? Can you flex or straighten your arm out? Can you bend your arm? Can you rotate your wrist? When you press on your arm, does that hurt? Is it warm? Does it feel puffy? So you can get a history and physical that way. And the limits of musculoskeletal exam, it relies on a family member or a patient to palpate correctly. It relies on the ability to appropriately see the patient in the video. Sometimes, maybe the body habitus or maybe the position that you might not be able to do that. It allows you, it relies on the ability of the patient to adjust whether, if they have gout or if they have arthritis, is it warm to you? But what feels warm to me might not be of concern as opposed to what the patient feels is warm. And you can't really rule out things like a possibility of a fracture. So you don't want to say, if you think that you're entertaining a differential diagnosis of fracture, you want to recommend that patient probably come to the ER. So even like in a neurologic exam, you can do some cranial nerves, like I had a patient stick out their tongue, squeeze their eyes really tight, smile, you can have them walk, you can have them talk, you want orientation, person, place, and time, muscle strength, sensory, cerebellar, exam, reflexes. And rectal exam and cessation, you can't do that. You're not going to ask somebody, or, that's something you cannot do. All right, so I'm going to show you a video. I'm hoping I'm going to show you a little video clip of how this is from Thomas Jefferson. It's a telehealth course. It's just a video clip that I probably shouldn't be using, but it's perfect to do. I'll show you just this one clip. I have 3 clips, but it'll take a while. What's our time? Oh, I've been talking for a while. I'm going to just show this one clip on how exam can be done, and then I'll entertain questions if there are any. Is that okay? Ross?
Perfect.
That's
You
perfect.
can show as many clips as you want.
Can you turn the volume up?
Hey? Oh, I don't know. Does that help? I'm not yelling, I'm sorry. Is that better? Well, I guess I have to talk.
You have to go back to the video now. I can't hear it.
Oh, shoot, what did I do? I'm sorry. Ooh. What is it? Oh, I did something, I'm sorry. Hold on. I have to get out of the PowerPoint. Ugh. Hold on 1 second. Shoot. All right, I'm sorry. I am probably not the best person to do this. Let me jump out of there we go. Shoot. Can you hear it?
No,
Not yet.
Can't hear it?
no, not yet.
Oh, because she's talking. I don't know how to. Okay, so the issue is me. Can you hear it now? Sorry,
No,
it's not talking.
it's not talking.
How about now?
Nope.
Right. I'm sorry. Maybe I can share the link or something. I don't know how to do it, so I'm sorry. But you can watch. Can you see the video?
Yes, we can see it clearly.
Okay, so let me show, maybe I can just show it. You can see. I have to do this. Oh, here, maybe if I did that. Let me try this one. Can you hear it?
No.
No. So this person is complaining of shortness of breath. They have a history of asthma. I don't know how to do this. Shoot. You can't hear it, Ross?
No, we can't.
All right, well, it's not helpful then. I don't know how to, I thought I knew how to do it. I don't. All right, so I'm not gonna show the video because maybe I can share the links and they can
That would be
maybe,
helpful.
huh?
That would be helpful.
Yeah, I'll just share the links, but pretty much I just wanted to end with showing the videos, but I'm sorry, I'm not so tech savvy, but let me see if I stop sharing. I stopped sharing. Maybe it'll play. I don't know. Hold on. Can you hear me still?
Yes.
Can you hear this?
Can everyone turn on their cameras, please?
You hear me?
Yeah, we hear you.
Do you hear the video?
No.
Okay. If you can't hear it, don't worry. I'll just share I'll share it. Sorry, I'm not really tech savvy.
No
Sorry.
problem. First of all, thank you so much for that very informative presentation, Dr. Offodile. At this time, we invite you to ask any questions. You may unmute or you can use the chat. In the chat, Dr. Offodile, during your presentation, 2 questions came through, but they came through at different parts. So one was, what about behavioral health? The other was this the same for behavioral health and psychiatric visits? So with that being said, I believe it says Will Carter III, and then the other one was Mr. Fleming. If you all want to unmute and add some more context to the question for Dr. Offodile, that would be great.
Dr. Carter, you can go first.
Dr. Carter, are you there? How did the patients respond is the question in the chat.
Respond to.
Are you able to unmute Dr. Carter just so you can give Dr. Offodile some more context?
Yes, sorry about that. So, yeah, when you were talking about the telehealth business and how the students and the trainers were going through the process, how did you all find the patient in the behavioral health or psychiatric setting to respond?
So how would a patient in a psychiatric setting respond to questions in a telehealth visit or the standardized patient or?
So at one point you were talking about the visits, if I heard you correctly. And so I'm just asking if there was a difference in a regular medical visit versus a behavioral health or a psychiatric visit. Like, were the patients equally as receptive in both settings?
So most of the things that we did were in a sort of in a simulation lab, and so what we, and even in a real setting, so most people are receptive to the telemedicine, but when you start engaging in I'm sorry, and behavioral health issues, and there is a higher likelihood that depending upon what the objectives of the patient, even in a clinical setting, depending on what the objectives or outcomes of patients as to how truthful they are actually in any clinical encounter. So even in a behavioral health, you want to be able to have the patient be in a setting that is amenable to them really sharing and expressing what's actually going on, and then also being able to ask the appropriate questions that will help to guide the patient. So in the simulated sort of environment, and the way we were teaching and using it for medical students and residents, the standardized patients were specifically trained on how to wait and anticipate a particular question. So that in any, whether it's simulated or whether it's in a real clinical encounter, the medical student or resident really has to be able to ask the appropriate question. And then, and they're also are really learning how to put patients at ease. And so when they are able to master those 2 things, then you should be able, they in that particular setting, you should be able to obtain the information that you actually need.
Hi, Dr.
So,
Foley. This is
yes.
Dr. Williamson. How are you?
Hey, how are you?
I'm doing well, thank you. So if I could just provide a little information about behavioral health and psychiatry regarding telepsychiatry. So I've been a provider for telehealth and telepsychiatry for probably about 10 years before the pandemic. And it was very much underutilized in terms of behavioral health. And a lot of times it was underutilized because academic centers weren't really familiar as much with the use of telepsychiatry. But once the pandemic hit, it was rapidly used by many in the academic setting and private setting. So So one of the things that occurred is that people really understood that you could do pretty much for outpatient visits, perform most of the behavioral health or psychiatric evaluation without much adaptation needed. So what often had happened is that people had to learn how to look at the camera and sort of toggle their view from the camera while they're also viewing the screen so that people could feel that they have eye contact. Once you learn how to do that, then the basic comments in terms of establishing rapport with a new patient or a follow-up a patient were pretty much the same. In many cases, historically and during the pandemic and continuing now, people looked forward to and gravitated to telepsychiatry visits because it often allowed them to have a visit anonymously without having to go to a mental health clinic or go to a psychiatric visit. Prior to the pandemic, telepsychiatry was mainly used connecting with rural areas. So as you said before, people wouldn't have to leave 2 hours away, take time off their job, take their child out of school, drive, get to the appointment, and then have the appointment and drive back. So often that was a whole day affair. But the pandemic showed us that people could have appointments and miss relatively little time from school or work and still continue to have their appointment. So I think psychiatry used and continues to use telehealth and telepsychiatry, even though many other specialties have not continued the use. Matter of fact, there's some people in terms of private practice offices are operating fully telehealth and telepsychiatry without having to establish an outpatient clinic or rent space. They can have a room set up in their own home if they want, set up as their office and provide telepsychiatry and mental health appointments to people full-time, 5 days a week from the comfort of their home, while patients are also working from or having appointments from the comfort of their location as well. So there are some challenges. So particularly with people who have psychosis or have a lot of movement disorders or side effects related to medications such as antipsychotics, for example, you wouldn't necessarily see that when you're just looking at their face or chest up, and you'd have to inquire about that during the exam. The pandemic also revealed to us some other challenges. You talked about confidentiality. So sometimes making sure, for example, as a child and adolescent psychiatrist, making sure that you give time for the parent to step out of the room, away from the door, so the child or teenager can share things confidentially. Sometimes people didn't really think through when they were having their appointment. So as an adult, for example, connected with us while they were on vacation at a theme park to conduct their telemedicine visit. And we actually told them, no, we can't do it this way. We need to have a confidential special time. Other times people would connect for their telepsychiatry appointment while they're driving in their car. And I'd actually have to ask them, I need you to pull aside so that we make sure you're not distracted. So while it was very much convenient in some places, we had to really educate people about the privacy, about the time, specified time, so that we could actually have time to communicate with them. But it was very well received because, as many of you may be aware, the COVID pandemic presented times when people had much more problems with anxiety and depression. And it was much more challenging for people to connect and get to a mental health provider. So this actually provided a way for people to connect in ways that they wouldn't have been able to. And early on in the pandemic, they relaxed the rules. So normally we wouldn't have been able to connect with people in other states if we weren't licensed in those states, but they relaxed those rules so that when people left college and went home across the nation, we could still do telemedicine appointments now. One more thing, at this point, there have been some advances in terms of intrastate compacts so that certain states recognize the importance of being able to travel, to communicate across state lines, but that has not advanced as much as we wanted it. And so we've had to tell people that we can only have their telepsychiatry appointment in the state in which we are practicing. So those are just a few things that I can share with you in terms of how telepsychiatry or telemedicine has been able to be practiced in and have changed during COVID and after COVID.
Thank you so much, Dr. Williamson.
Dr.
We do have some
Williamson.
additional, we got some other questions coming in the chat. So it says, is there any resource in place for patients who don't have education or access to smart devices? Dr. Offodile?
A lot of times the patients can get these devices, and Dr. Williamson can help me with this, is they can get their device through their healthcare provider, or their health insurance.
Awesome.
Or,
Dr.
you
Williamson,
know,
want to add on?
Go ahead, Dr. Williamson.
Sure. For telepsychiatry, I think one of the main things is making sure you're using not only a device, but you're using a platform that is HIPAA compliant in terms of private information. So we actually shifted from Zoom, and we've used a platform, for example, called Procol. There are multiple ones out there. But in terms of devices, it's making sure that the device you use is HIPAA compliant. Alternatives such as using a telephone don't really count as telemedicine to being able to provide those sorts of clinical visits. And so if they don't have the device or the platform, then, and they're not able to access it, then that's another limitation in terms of mental health.
Thank you. I'm checking the chat, making sure I did not miss anyone. I do not see it. I see lots of compliments. So Dr. Offodile said, excellent presentation. Thank you. Lots of great comments coming in. Does anyone have any additional questions? You can unmute and ask your question at this time. I also want to say good evening to Dr. Patricia Matthews-Juarez, who is on as well. And another comment just came in. This has been great. Thank you. All right. So thank you all again for joining. At this time, I am going to turn the program back over to Mr. Ross Fleming, who will give us directions so that we can complete the survey. And Dr. Offodile, the comments are coming in. The chat is on fire. It says, thank you so much. This was excellent. Another thank you. Very informative presentation. Thank you. Thank you very much. So on behalf of our team, we want to say thank you so much for taking time this evening to share your time, your expertise. We will continue to call on you as we explore this topic, and are excited that you are family and you always engage with us. And there's another thank you very much. So Mr. Fleming, there's nothing more.
I'll always be part of the Meharry family. So, you know, I love Meharry. So
Absolutely. Thank you. Thank you. Thank you. So again, more comments. So Dr. Offodile, all I'm saying is thank you very much, informative. And as soon as I read it, they keep coming in. So Mr. Fleming, I'll turn it back over to you. Thank you all again.
Thank you. Thank you. Thank you so much, Dr. Offodile, for taking the time out of your very busy schedule to speak with us this evening. And I know we have a lot of comments coming in, but so I wanted to make sure that I get this survey in the chat box before everybody signs off. So make sure everyone looks at the survey in a chat box and make sure you fill that out as soon as you can, before you leave, if possible. Again, I want to thank Dr. Offodile for that very informative lecture. And I'm trying to get this off so I can see. Did I lose you guys?
No, we're here.
Okay. All right. So thank you once again, Dr. Offodile. And again, we would like to invite you back again. So when you have enough
Okay.
sometimes I really appreciate you taking time out to accept our invitation. Does anyone else have any questions in the chat
I
box?
wanted to say thank you to Dr. Williamson with her specific expertise.
You're welcome. You're welcome.
We need to take our show on the road together.
We can do that. We can do that. Absolutely. Anytime to connect with you would be great. Thank you.
Alright.
Totally.
You're welcome.
Thank you so much. I want to reach out to Dr. Matthews Juarez if she has any comments at this time before we close.
No, it's been exciting to hear Dr. Offodile, and we had an opportunity to see her in her new element at Charles Hall Drew University of Medicine and Science, and she was exceptional there as she was tonight. So when you get a chance, if there's a session that is offered by her from Charles Drew, please, sign up to hear her. I think that the work with Dr. Williamson here and with Dr. Offodile there, that we can make sure that each of you get a really good grounding in telemedicine and telepsychiatry, especially now as we still will continue to be isolated and dealing with long COVID and the issues of children having to face some of the issues around, not being able to be as competitive as they should be in school and all of the things that come with that. And so the idea of telemedicine and telepsychiatry around suicide and ideation among young people will be really something that you guys will be able to help in these remote rural communities as well as in inner city. So I thank Dr. Offodile, and as always, looking forward to hearing her again. And she's always terrific, and we look forward to her continuing as a wonderful Meharryan, no matter that she's in Los Angeles now. Thank you so
Absolutely.
much, Ross.
Thank you, Dr. Matthews Juarez. And I'd like to say good night to everyone and just remind everyone to still please look in your chat box and look at the survey. Sorry, it's not there. I just posted it.
Yes.
Posted it again.
And Dr. Ross, I do want to encourage everyone to start back thinking about in-face and in-person sessions on Tuesday night. I know these sessions that are on Zoom, so it's very exciting, but they're also excited. It's exciting to be in person on the campus. We do provide dinner, and so for an hour and a half to meet and to reconnect with your friends will be pretty exciting. So please consider coming back to these sessions. I don't know how many people were in the sessions, in the session on the campus, but it's an opportunity to meet and greet and to learn and interact. So thank you again for this opportunity to invite you back to our in-person sessions.
Thank you, Dr. Matthews Juarez. I really appreciate you saying that. And so once again, I'd like to say good evening to everyone. And thank you, Dr. Offodile. Really appreciate you. So good night, everyone. And thank you for joining us.
Thank you, everyone, for your time. Appreciate it.